The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
We got the COVID vaccine.
We got the COVID vaccine.
So have I. We have too.
Now that I'm vaccinated, I feel relieved, hopeful.
It's changed my life.
It feels like we've got our freedom back.
We can get out and go around and visit people.
I'm out of the cage now.
My dad is 94 years old, and I am just looking forward to spending a bit more time with him.
We can't wait to hug our grandkids.
I'm looking forward to going swimming.
We're looking forward to traveling.
And seeing my good friends.
To know that we're going to be able to meet our grandson, who we haven't gotten to meet yet.
It doesn't hurt. It doesn't cost you anything, but it does protect you and it protects lives of others.
I think getting the vaccine is the only way to get Ohio back to normal.
Please get the COVID vaccine.
Protect yourself,
Your family and your friends.
It's a game changer.
Don't hesitate.
Don't hesitate.
Vaccinate.
Hello, my name is Ursel McElroy. I am the Director of the Ohio Department of Aging. It is my pleasure to join you today to discuss the very important topics of visitation, vaccines, and testing. It has now been a year since the beginning of what is arguably the largest public health emergency most of us will experience in a lifetime. COVID-19 took aim at older adults, threatening their health, their needed services, their interactions with loved ones, and their lives. And throughout, you have been called upon to be brave, flexible, and resilient, among other things, and I thank you. While we are still in the midst of the pandemic, I am encouraged that we have opportunities like today to begin restoring the critical connections we all very much need. And during this hour, although the lines will be muted, please feel free to use the question function, and we will make every effort to post helpful information, tools, and resources to address any questions you might have today. I am joined today by experts in post-acute and long-term care medicine. It is my pleasure to introduce to you today our panelists, Dr. Brian McLean, Dr. Thomas Lehner, Dr. Todd Sobel, Dr. Robin Jump, and Dr. John Wigand. Last week, the federal regulations issued by the Centers for Medicare and Medicaid Services, known as CMS, turned our attention to nursing home visitation. And it updated some of the regulations and some of the things that we are allowed to now move forward with. We understand that the physical separation from family and other loved ones has taken a physical and emotional toll on residents and their loved ones. And so today we'd like to take a moment to discuss what those new guidelines entail. It addresses the core principles, one of screening all who enter the facility for COVID-19, making sure that we utilize good hand hygiene, face covering or masks. It emphasizes social distancing of at least 6 feet, instructional signage, cleaning and disinfecting high-touch surfaces, making certain that we have appropriate staff use of PPE, effective cohorting of residents, and being certain that resident staff testing is conducted as currently required. Now, the new regulation does require visitation unless there is a high risk of COVID-19 transmission. So what does that mean? When, in fact, do we limit indoor nursing home visitation? Well, according to the new memo, unvaccinated residents, when the nursing home's COVID-19 county positivity rate is greater than 10%, and when you have less than 70% of the residents in the nursing home fully vaccinated. If you look at the pie chart, this gives you an example of where we are within the state. Understanding this is very fluid, This is the data as of 3/7/21. We have 173 of our facilities that fall within that COVID-19 county positivity of red. But that alone does not mean that an unvaccinated resident cannot have a visit. It also has to be coupled with having a facility that has less than 70% of the residents within the facility being fully vaccinated. The other limitation is when residents have confirmed COVID-19 infection, whether they are vaccinated or not, and when a resident is in quarantine, whether vaccinated or unvaccinated. We also limit indoor visitation when a new case of COVID-19 is identified. The first thing we have to do is suspend visitation. Now, when that first round of outbreak testing is done, if it reveals no additional COVID-19 cases in other areas of the facility, in other words, if it's contained to one place, visitation can resume for residents in areas without COVID-19. So, if, for example, if the COVID-19 is contained to one unit or one area, while visitation will be suspended for that area, it can still continue for other areas. However, if that first round of outbreak testing reveals one or more additional cases in other areas of the facility or multiple units, visitation should be suspended for all residents. Another change from the CMS regulations, if a resident is fully vaccinated, they can choose to have close contact. This includes touch with their visitor while wearing a well-fitting mask and performing hand hygiene before and after. This is a significant step in terms of visitation and moving forward. Also, we found within the regulation, compassionate care visitation was revisited. This is something that has been allowed throughout at all times, and it is not limited to end-of-life situations. Anyone that can meet the resident's needs should be able to provide compassionate care visits. That could be a family member, clergy, lay persons offering religious and spiritual support. We have now examples of compassionate care that we find within the memo. Some of the compliance considerations related to this revised memo, concerns related to resident communication with and access to persons and services inside and out of the facility. If a facility limits visitors without a reasonable clinical and safety cause, if there's concern that the ombudsman access to the resident and the resident's medical records has been hindered, or if there's lack of adherence to infection control practices. These are things that the surveyors will assess for as it relates to compliance with this particular memo or regulation. If we turn to the health director orders, in other words, our state orders, many of the general requirements remain in that order. As we begin to evolve the order, though, I would like to call your attention to a few things. Many of the safety standards for routine visits will remain. So screening for symptoms, logging each visitor, ensuring that visitors wear face coverings, the clause on the age of maturity, making certain that the individual is mature enough to be able to safely distance and to follow instruction. 2 visitors per resident per visit, still requiring individuals to schedule in advance, and there's an expectation they will utilize good infection control practices. We will also continue to insist that the facility develop visitation policies consistent with the order and educate residents and visitors about the risk of the spread of COVID-19 and the appropriate safety measures to take to protect themselves. Some things that you will find as the order evolves that are different is that there will be a minimum recommended amount of time to visit. That minimum recommended time is 30 minutes with facility discretion. This will be different in that the current order requires a 30-minute maximum, whereas now we're recommending a 30-minute minimum. Also, visitation taking place in a designated visitation area, which may include a resident's room. Again, this is different than the current order and this will evolve within the upcoming order. I want to talk a bit about COVID-19 testing. This is one of the tools that we have to keep individuals safe. You should see on the screen the CMS requirements that are currently in place. CMS utilizes testing to enhance our efforts to keep COVID-19 from entering and spreading through nursing homes. And the facilities are required to test residents and staff based on the parameters and set forth by CMS. You have testing triggers of symptomatic individuals, if there's an outbreak in a facility, or routine testing. When we look at symptomatic individuals, it's the staff with signs and symptoms that must be tested, and if there's a resident with signs and symptoms that must be tested. For an outbreak, you test all staff that previously tested negative until no new cases are identified, likewise for residents. And then routine testing has been based on community spread, and it's not recommended for the resident unless the resident leaves the facility routinely. So again, symptomatic testing. Staff with symptoms or signs of COVID-19 must be tested, and you will take appropriate action based on the results. Outbreak testing, defined as a new COVID-19 infection in any healthcare personnel on any nursing home onset COVID-19 infection in a resident. And upon identification of that single new case of any staff or resident, all staff and residents should be tested. And this requires that the staff and residents that tested negative should be retested every 3 to 7 days until testing identifies no new cases of COVID among staff or residents for a period of at least 14 days since the most recent positive result. What I have on the screen now compares the current CMS requirements and the current ODH guidelines. As you can see, and as you're familiar with, the minimum testing frequency under the current guidelines are twice a week, regardless of the color of the county in which the facility sits in. As we begin to evolve the order, we begin to look at how we can update current guidelines. Moving in the direction requiring minimally testing for vaccinated staff, weekly testing for vaccinated staff. You can see the different guideline, future guideline, again, of having vaccinated staff test weekly, whereas unvaccinated staff would continue to test twice a week. When we define vaccinated staff, we're referring to those who are fully vaccinated, and that is an individual who it's been more than 2 weeks following receipt of the second dose in a 2-dose series, or more than 2 weeks following receipt of a 1 dose of a single dose vaccine. So how will we support this testing? Many of you are familiar with state-supported testing options, and those will remain. Option 1. We will continue to provide alternating PCR and rapid antigen test support. That looks like 2 rounds of state-supported PCR and 2 rounds of antigen tests per month for a vaccinated staff person. That's 2 rounds of state-supported PCR and 6 rounds of antigen tests per month for an unvaccinated staff. And we will continue to provide 4 rounds of state-supported antigen tests per month for residents. So let's take a look at this on the table. Weekly cadence for a vaccinated staff in comparison to the twice weekly cadence for an unvaccinated staff. If you look at week 1 for a vaccinated staff, it could go as follows. PCR test week 1, antigen test week 2, PCR week 3, antigen week 4. However, for an unvaccinated staff person, PCR test week 1, followed by an antigen test later that week. Week 2, rapid antigen test, followed by a second antigen test. The third week would be PCR, followed with antigen, and then the final would be 2 antigen tests appropriately spread out. So let's talk about option 2. Option 2 is rapid antigen tests only, in which case we would provide 4 rounds of state-supported antigen tests per month for vaccinated staff and 8 rounds of state-supported antigen tests per month for unvaccinated staff. And you would still receive the 4 rounds of state-supported antigen tests per month for residents. So let's take a look at So how does this roll out on the table? The weekly cadence for vaccinated staff, again, compared to the twice weekly cadence for unvaccinated staff. Week 1, they take the antigen test, the same for weeks 2, 3, and 4. The only difference for the twice weekly cadence for the unvaccinated staff is that they would receive the rapid antigen test twice that week, again, appropriately spread out. And then finally, we have option 3, PCR test only. And in this case, there would be 4 rounds of state-supported PCR tests per month for vaccinated staff and unvaccinated staff. There would also be 4 rounds of state-supported PCR tests per month for residents. Now, certainly we understand that there's still 4 rounds left for the unvaccinated staff, in which case you could fill that in with the antigen. You just receive a higher amount of PCR when you select the PCR tests only, or you could, in fact, request additional PCR. And then we have option 4, those who opt out of state support. And simply that means that you are fully responsible for supplying the testing. This does not mean that you are not required to test at the cadence set forth in the guidelines. It simply means that you are assuming full responsibility. At this time, I'd like to turn it over to Dr. John Wigan to talk about the clinical case for testing. Dr. Wigan?
Thank you, Doc. Thank you, Director. So this year has been unprecedented. I think I've heard it said that we've used the word unprecedented an unprecedented number of times this year. It has been a challenging year, obviously. And when we think back to where we were a year ago, testing supplies are now readily available as opposed to last year when we were struggling to find swabs and reagent. And now we certainly have a much better understanding of the behavior of COVID-19, both in our community and in our facilities. The fact that there are individuals who can come in totally unaware that they are infected with COVID-19 and potentially spread it before they develop symptoms, or they may never develop symptoms, but yet they're infective. So we have a much better understanding of that behavior. And certainly the pandemic has taken a significant toll on those of you who are listening to this, the employees and staff of congregate care settings. You have experienced COVID yourself in some cases. You have been asked to test on a regular basis and even twice weekly. We know that you have had coworkers and in some cases residents of your facilities who have had great difficulty with this infection and in some cases succumbed to it. So we understand that significant toll that you have felt. And certainly the residents that we care for have suffered as well. So an executive director that's a friend of mine a month or two ago really used a great analogy that he felt like we were like a turtle over the past 11 months where we were, drawn into our shell. And, the need for recognition of the challenges that our staff and our residents have gone through really beckoned for us to start sticking our neck out a little bit. And when I thought about that, and then I found this African proverb that, like the turtle, every man or woman must stick his or her neck out if he or she wants to go forward. And that's really where I think we are now in Ohio. We feel like we need to move forward. And I think that this is going to be the first step in that direction. So I'd like to use a couple case studies to help demonstrate the clinical call for testing. And so this is an example of a nursing facility that identified 2 positive employees who directly interact with residents out of 120 total PCR tests that were done on a regular cadence testing. So 2 of those residents were positive. Both of the positive, employees had received their second Pfizer vaccine through the Pharmacy Partnership Vaccination Program 3 weeks before testing positive. And interestingly, neither were symptomatic, and one actually had a medical condition that possibly caused her to be immunocompromised. So this causes questions to come up, and these were posed to me. How could this be accurate? And aren't those tests false positives? And so I'd like to ask Dr. Robin Jump to go ahead and answer those questions.
Okay. Hi, everybody. Thanks for having me on this call. And I'd like to thank Director McElroy and the Ohio Department of Aging, as well as Dr. Wigand and the clinical advisory group for allowing me to be part of this. So how could this test be accurate? As it turns out, the PCR tests are really, really good with very few false negatives. And while there can be false positives, in this case, they're not false positives. These are real. And these are folks that developed an asymptomatic COVID infection despite having received the vaccine. Remember that the vaccine is 95% effective against the wild type strain that we first had throughout the world, in Ohio specifically. So these 2 individuals are among the unfortunates that we're not in that 95%. And this happens. We are going to see the occasional person that does wind up getting COVID infection after a vaccine. But here's the great thing about getting the vaccine is that some protection is better than none. And anyone who gets the vaccine and then gets infected will have a less serious infection than they would have ordinarily otherwise. And I think especially about people who are immune compromised. We don't know how well the vaccine works in those people. We know that it works, but it's not going to work maybe at 95%. Maybe it works at 80 or 70%. But regardless, it works. And it keeps them from maybe having to go to the hospital. It keeps them from being miserable at home. And maybe it just keeps them at home while they wait for the course of illness to go away, frustrated and a little bored. And isn't that a lovely place to be, as opposed to in the ICU and intubated, which is where I'm seeing a lot of our patients wind up still. So it's okay. It's not a perfect vaccine, but it's really, really good. And it prevents those really serious side effects and outcomes.
Thank you, Dr. Jump. So this is a slide, a graph that I use quite frequently. I think it helps explain the differences and limitations really between the PCR test and the rapid antigen test. So the PCR test you can see is in the gray line, and the rapid antigen test is in the red. And if you look at the exposure to the virus being on the horizontal axis at -1, and those are in weeks, usually it will take about a week for an individual to start really developing symptoms. Sometimes, as we mentioned, they don't develop symptoms at all. And both the PCR and the rapid antigen within several days can start demonstrating positivity on each of those tests. The difference, however, is the PCR test will tend to have this long tail that can extend out for weeks and sometimes even months. And I'm sure some of you remember back last spring and early summer when we were trying to clear people from their COVID infection using testing, and they occasionally would have a positive test and then a negative test, and then we repeat times, and it would ultimately turn positive, alternating with a negative. And that's because that they were infected at that point, but often they just release viral particle, cause the PCR because it's very sensitive to demonstrate a positive test. Compare that to the rapid antigen test, which really drops off almost as fast as it rises, and so such that within a week or so, the rapid antigen test can be negative. And so that's important for us to keep in mind as we think through some of this testing cadence that we've made recommendations towards. So the second case study is imaginary. You'll figure that out relatively quickly. This is Windy Meadows Nursing and Rehab, which has taken advantage of the state-supported testing using rapid antigen tests. And Nurse Nelson did not elect to be vaccinated when it was provided by his employer. Can you go ahead and go back? There we go. And so he was tested on the 5th of April, Monday, using an Abbott Binex Now card, and it was negative. He got the results within 15 minutes and he went to work. Well, that night, Nelson decided to go over to a friend's house to watch the NCAA basketball championship game. And unfortunately, he was, unbeknownst to him, exposed to somebody who had COVID-19. And he ended up contracting that infection, but he remained without symptoms. And so based on the Windy Meadows state-supported testing, on Thursday, April 8th, he once again tested again with a Binex Now card, and this time it was positive. And because he was asymptomatic, and the recommendation is if somebody's asymptomatic and they have a positive rapid antigen test, he was checked with a confirmatory PCR test, which several days later, after he had gone home, obviously, and been isolating, ended up finding that PCR test confirmed the rapid antigen test. It was positive. So this raises a couple questions, and I'm going to ask the first question to one of our panelists, Tom Lehner, and then I'll ask the second question to Todd Sobel. So, Dr. Lehner, is it necessary for unvaccinated staff to be tested twice weekly?
Yeah, we do feel and believe that our residents should be, our staff should be tested twice weekly. And the reason for that is several. First of all, I think we all agree we want to keep our residents, staff, their families, visitors safe. I think we all agree on that, and that's been the objective of the testing all along. We also know that more than 50% of the new cases come from people that come into our buildings, and in this case, employees that test positive. So they're asymptomatic, but they're carrying and shedding the virus. We also know that that based on the curve that Dr. Wiegand showed previously, that people that are unvaccinated also may be at greater risk for shedding larger quantities of virus compared to the cohort. So that makes them, to use a phrase we've heard, a super spreader. They have the possibility of spreading more virus around to the people they come in contact with, and they don't even know they have the virus. And I think finally, it's important that we continue to test, because that's really the way out of this pandemic that we're in, and keeping ourselves and everybody else that we interact with safe.
Great, thank you, Dr. Lehner. Dr. Sobel, will Nelson positive test all visitation need to be discontinued at Windy Meadows these 2 weeks?
So
I think you're muted.
Patient as possible. Of So the intent.
Is that the
specific unit in the only the
So I'm not sure if anybody can hear me. Dr. Lehner, do you want to try to pose that question? Answer the question of Nelson's positive test?
Sure, I think I'll video off so that will help. Yeah, so and based on the CMS guidance that Director McElroy talked about in the very beginning of the meeting here, it doesn't necessarily mean that all visitation will have to be discontinued. It's important to remember that we need to identify where the vaccine, if the infection is isolated unit or not. If that's the case, zoomed in other parts, just not on that unit. Members, other up in so directions of CMS that this goes all together. Outbreak.
Slide. To the next slide. So we'll, a quote that I heard from John Tudor is, technology makes it possible for people to gain control over everything. except over technology. So hopefully we'll overcome these little glitches. But I'd like to go ahead and lean on Brian McLean, Dr. McLean, to talk about a new innovative program that is now present in Ohio called the RAP program, or Regional Rapid Response Assistance Program. Dr. McLean?
Thanks, Dr. Wigan. I'm happy to be with all of you today to talk about this program. And since the last quarter of last year, under the direction and help of Director McElroy, this group has been meeting on a really daily basis and is comprised of a multidisciplinary team, including regional operational coordinators, which are supplied by the National Guard, regional medical directors, of which some of the folks on this presentation participate in, and specialists in infection control, PPE coordination, outreach team for vaccination testing. We have social workers and chaplains working with us as well. And we have been working with nursing and assisted living facilities, as well as adult day and group home and low-income senior housing to provide vaccine clinics, protective equipment, and infection control and outbreak assistance. We've been using as a multi approach and to both assist a firm plan for anybody that needs to reach out. This holistic, they're in congregate settings, and we believe that this will be a replicable program that will morph into something for other healthcare emergencies, hopefully not at the degree of this one. So look forward to working with all of you, and thank you. We can go to the next slide.
So if you can back up one slide, I just wanted to be able to show the individuals who are part of the RAP regional teams: Dr. Lehner, Dr. Jessica Coleman, Dr. Sobel, Dr. Cantor, Dr. McLean, Dr. Shank, Dr. Marla Haller, and Dr. Muma. And then the clinical advisory group is really a diverse group. Some of the state agencies are represented in that. And then we have individuals like Dr. Stone and Dr. Jump and Ellen Fox who don't work in the state, but who are experts. And so, of all these individuals on the slide point, and we'll can you go ahead and advance this slide? So we want to spend a little bit of time talking about how vaccinations have provided an opportunity for us to rethink visitation. Next slide. So the clinical advice was about while thinking to be an opportunity response of COVID we are what are considered. We also under variations in not only visitors. This adverse in our next slide. Is a known as and is that by themselves. In fact, there are no within. Think about how we came up with a number to use line of defense. All under the use of identifying not visit. It's not mandated. Using the rapid antigen that we have to and then certainly for the rapid antigen test, we're going to continue to recommend masks. We're going to continue to recommend masks and continued use of hand sanitizer as a means, a well-accepted means of preventing the spread. And then finally, continuing to talk about vaccination as being really the best way for us to move forward through this pandemic. And I'd like to invite, hopefully, Dr. Jump, or really any of the panelists to weigh in who were in the process of kind of discussing these different methods of Swiss cheese, if you will.
Sure. So it's Robin Jump. Hopefully you can hear me. And I love this Swiss cheese model as kind of how we think about errors in how errors and mistakes happen in systems. And our job in healthcare is to make things as safe as possible for the people for whom we care. And we try to build those safety factors into several steps in our system. And that's what we're proposing here for protecting our loved ones in nursing homes from becoming infected with COVID-19. So we can't keep everyone safe 100% of the time, but we can certainly take several reasonable, rational, not really so terrible steps to make this a good, strong possibility for everybody. So that's a screening and temperature survey on when people come in to visit, a rapid antigen test for those to help us figure out people that might be shedding virus but don't know infected. Those that get through that and may still be wearing a face mask, virus from spreading, and then hand sanitizer to keep virus. And finally, vaccination. Keep hearing is the best thing that reduces the risk of infection. Thank you.
I think it's a highlight that shared communities are kind of defined as these interconnected facilities where there's a nursing unit, a nursing facility adjacent to an assisted living facility. And these are especially challenging because the different regulatory compliance between those two settings can cause some confusion and has caused in how we make recommendations for testing and managing COVID. Obviously, the staff of a facility may be asked to provide coverage in the nursing facility one day and perhaps the assisted living the day, or sometime and covering at the facility or opposite area of the facility. And then obviously COVID is really a non-discriminatory virus. It will go where it goes, and it won't stick to one facility, one section of the facility, like living or skilled. And understand that shared community has some difficulty. Really, the testing guideline hopefully will across as well things in these skilled and long the vaccination to Visitation of the wrap breach need to continue that hopefully full implement parameters that we will the interim success and
Thank you, Dr. Wygand. We are continuing to have some audio and visual issues, so we're going to go ahead and wrap up the webcast right now. We will have a recording of this with all the slides available to share with everybody on our website as well as our YouTube channel. So we apologize for the technical difficulties, but we will end the webcast for today and then have a full recorded version, full audio and video available for you. Thank you all for joining us.